Good morning, everybody, and welcome to Grand Rounds at the University of Nebraska and the Children's Hospital. Our speaker this morning is Dr. Melissa Muff-Lewitt, who's the Medical Director of Dialysis at Children's Hospital and Medical Center. She's an Assistant Professor of Pediatrics at UNMC. She earned her medical degree at the University of Minnesota Medical School, followed by pediatric residency and nephrology fellowship at the University of Iowa. She's been with us since September of 2015, and a delight to have you here. So please join me in welcoming Dr. Muff-Lewitt.
Thank you, Dr. Sparks, and thanks for everyone coming today. Thank you for the opportunity to speak with you today. Dr. Harper had asked me to come and talk about a nephrology topic a few months ago, and I was trying to think of something that would be, useful for everyone. And when I thought about what we see most frequently in the hospital as far as kidney diagnoses, I think it would be acute kidney injury, and so that's why I thought it would be good to talk about today. I set out to kind of talk about what's new in acute kidney injury, but thought once I started, discuss things that are new at the end, but I thought maybe just to make sure we're all on the same page, I'm kind of going to spend some time at the beginning just kind of defining acute kidney injury and making sure everybody kind of fully understands what we're dealing with acute kidney injury. So, really just working on defining acute kidney injury, hoping to explain to you why we should care about acute kidney injury, why this affects everyone in the hospital. Really, it's something that we should all be looking out for, and why we need to care about it, what it does for our patients. Talking a little bit about risk factors, the causes of acute kidney injury, treatment and prevention, some of those new advances or new directions, and then through it all, we'll kind of talk some about like the prognosis of acute kidney injury. And so we're going to try to rush through all this. So what is acute kidney injury? So really it was formerly what we called acute renal failure, but we're trying to kind of get away from that no more as much and make sure that we're aware of earlier injury before we're dealing with kidney failure. So it's really an abrupt decline in kidney function. So you may or may not see a decrease in the glomerular filtration rate, and it may or may not lead to an increase in creatinine, may or may not lead to an increase in urine output, but the risk is high in all hospitalized patients, especially in our ICU patients. So why is AKI a problem? Well, like I said earlier, it's the most common diagnosis that we see in the hospital. It's the majority of the consults that we see. And the incidences really varies throughout studies, and it kind of depends on what definition is used, and we'll get a little bit into the definitions of acute kidney injury. But in the literature, it's reported as low as maybe 15% in some studies, and up until like the 50 percentile in some studies. So I would say, like on average, it's around 30% in the hospital population. So what happens with acute kidney injury? Well, we see that it can lead to decreased urine output in our patients and fluid overload, loss of electrolyte regulation, loss of acid-base regulation, and impairment of our nitrogen waste product excretion. So we see that increase in BUN. But what I'm hoping to kind of convey today is that really acute kidney injury is not just a problem with BUN and creatinine, right? A lot of people say, well, those are just a lab value, but there's other things that are going on. And so this slide just tries to convey that, okay, we all know with acute kidney injury that, let me try out this new pointer. Okay, so we all know that we can get fluid overload with acute kidney injury. I think all of us have seen that, and we've all seen electrolyte and acid-base abnormalities. But other things that are starting to be more well-studied in the literature are what other effects, when the kidneys aren't working, does this have on the body? So there's studies that are showing that it affects our immunity. We're seeing long-term effect studies that are showing this is resulting in chronic kidney disease in our patients. This isn't just a temporary thing in the hospital. This is resulting in more long-term. And then there's also these new theories behind the effects of kidney dysregulation and kidney injury in cardiac patients. And there's a lot of studies on cardiorenal syndrome now. and also effects on the brain. So everybody, I'm sure, is, if you've not, you've kind of heard mention of Press syndrome. I mean, there's a lot of different things that when the kidneys aren't working right, and you have dysregulation of blood pressure and fluid balance and everything, that you can get into these neurorenal syndromes. So in general, when I sought out to do this talk, I don't think I fully realized how much literature there is out there on acute kidney injury, and the amount of studies is just astronomical. So I tried to do a lot of summing up on slides and kind of show some of the high points, stick with some systematic reviews. But essentially the general conclusions from most of these studies is that in general, acute kidney injury is associated with poorer outcomes in our patients. So we see increased mortality with our patients in the hospital, and we'll talk a little bit more about that in some studies. We see prolonged length of stay, and that holds true for both non-critically ill patients in the hospital and patients within the ICU. These patients in the ICU have been shown to have an extended duration of mechanical ventilation, so that makes sense, right? If they're significantly fluid overloaded, they're going to have sick lungs and ARDS. AKI with fluid overload has repeatedly been shown to have an association with increased risk of death, even when associating for other confounding variables. So when they're correcting for like PRISM scores and how sick the kids are in the ICU, fluid overload is still seen to substantially increase mortality over some of those other factors. An increased number of hospital readmissions in these patients with acute kidney injury. They're showing long-term, these patients have more recurrent physician visits, and that's not just nephrology visits, that's all physician visits. And there's an increased risk of chronic kidney disease, so not just an acute injury, but progressing into something more long-term. Increased risk of hypertension, increased risk of proteinuria, so those are all the things that we always monitor for in these patients long-term when they come to see us. And then in adult studies, they're actually showing increased risk of other cardiovascular events like stroke, MIs, things like that. So let's first, before we get into some of these studies, we have to kind of better define what AKI is, what acute kidney injury is. So this has been kind of a progression over time. There are more than 30 definitions published in the literature as far as what acute kidney injury is. And so we kind of started out first with this rifle criteria. And so essentially this stratified into kind of progression of acute kidney injury stages. So risk, injury, failure, and then they even moved into like loss of renal function, and then E for end-stage renal disease, which is our dialysis-dependent patients. But essentially what you had to do is meet criteria based on creatinine or a change in urine output. And so initially with this rifle criteria, they were looking a lot more at like decreases in GFR. And people were kind of struggling with calculating GFR, and so then there's other models that have come about where people were looking more at just an increase in creatinine, and so that's where the Aiken criteria kind of comes into play, and then this KDIGO definition that we use as well in the kidney world. And so, but all of them are pretty similar. It's interesting, in a lot of studies there are, if you use these diagnoses, there's different percentiles of patients that'll flag with acute kidney injury, but overall they're pretty similar, right? And I can't say when I get an acute kidney injury consult that I necessarily always stage the patients, but I think the important thing to look at is just, so already you should be identifying these patients of having acute kidney injury with only, a creatinine 1.5 times their normal baseline. And so I think a lot of times we don't necessarily clue into things already at that stage. And then definitely we're looking at already moderate AKI when we have a doubling of creatinine. There is a more specific pediatric definition that's called the P rifle that, again, they tried to take the, adult criteria and specify it more to kids because it's really challenging, again, in kids to, a doubling of creatinine in a baby might be from increasing from a creatinine of 0.1 or 0.2 up to 0.3 or 0.4. So they really tried to focus more on GFR changes. So again, you're looking at just dropping your creatinine, you're already in the moderate category with the risk if you have a decrease in your GFR by 50%. And so again, that's usually I consider a decrease in GFR is a doubling of your creatinine, right? You've cut your kidney function in half. And then sometimes it's kind of hard to pick up on the urine output, but again, we're trying to kind of make it so it's clear, like if your urine output's falling in your mils per kilo per hour, you need to start staging for that. And again, you don't have to have both criteria for acute kidney injury. You can have one or the other. And then essentially what has seemed to be used most commonly in studies now is this KDIGO definition down here. And so this stands for kidney disease, what is it? Now I'm forgetting what KDIGO stands for. Kidney disease, improving global outcomes is what it stands for. And so this is what a lot more of the studies are following, is this KDIGO definition now. So, but like I said, most of the time these definitions are all very similar. So now that we know these definitions, what do these mean? So this was a systematic review from 2010 where they used the rifle criteria, and essentially these are, again, adult studies. All of these studies had 1,000 patients or more, and they essentially wanted to look at mortality associated to see if it trends with these levels of severity of acute kidney injury. So if you look, again, this is your risk, injury, and failure, and in all studies they showed that as you increased in your AKI severity, the mortality increased throughout all the studies. So that aimed to try to, make people aware that as you're, not only is, with acute kidney injury is mortality higher, but the more severe it is, your mortality risk is increasing. And so then this is another systematic review that was done where they sought not only to just look at the severity of acute kidney injury, but the length of how long the acute kidney injury was going on in the hospital. And so what they tried to do was look at essentially they kind of grouped all these into short, medium, and long duration of acute kidney injury. And then you can see by these forest plots here that as the duration increases, you're getting far away from that center access line, signifying that they're seeing a higher risk of mortality the longer that the acute kidney injury is going on. So what else have we seen in some of these studies? Well, not only is the mortality high, but the risk for CKD is high as well in these patients. So this is, again, these 1, 2, 3 stages of severity for acute kidney injury. And then they're looking for CKD stage incidence, so CKD stage 3. So that's already a moderate stage of chronic kidney disease. And they're seeing that patients that have more severe acute kidney injury aren't necessarily having, if you look at the change from stage 1 to stage 3, that's not really increasing their hazard ratio for developing chronic kidney disease. But again, the duration of how long the acute kidney injury is going on is what's really increasing the risk for chronic kidney disease. So these patients that are having acute kidney injury reported for greater than 10 days are the ones that have the greatest risk of chronic kidney disease in all levels of severity. More specifically for pediatrics, when we've looked at some of the outcomes, there was a study called AWARE. And so essentially with that, they were looking for acute kidney injury, and they were looking for severe acute kidney injury, so that's stage 3 in critically ill children, greater than stage 2, I spoke. And they were looking only in critically ill children, and they saw that the risk of acute kidney injury was about 15% in these 3,000 kids. And the interesting thing is they saw that 69% of these patients met criteria for acute kidney injury just with their creatinine as a marker. 18% met with only their urine output criteria, and only 12% met for both urine output and creatinine criteria. And then they were looking at the mortality risk with this curve. This was a survival curve here. And so really they found in their study that oliguria is a major risk factor for kids that have acute kidney injury. So if you go through the chart here, essentially, so group 1 is no acute kidney injury, 2 is just a change in creatinine, and you see that a change in a decrease in urine output is slightly increased risk of mortality than the creatinine marker alone, but when you had both a change in creatinine and a change in urine output, the mortality was significantly higher. So in summary, from what I reviewed in a lot of these studies is really just that the AKI incidence varies based on the acute kidney injury definition, and kind of varies based on the population that's studied, whether the patients are critically ill or non-critically ill. Patients that have more complex or critical illness are at greater risk of developing acute kidney injury, which makes sense, right? Pediatric AKI mortality varies based on the underlying diagnosis, and I think that makes sense, and we'll get into that with, when other diagnoses are involved, like some of our hem-onc patients. Younger and more critically ill patients are at increased risk. There's a lot more studies coming out on neonatal acute kidney injury and the mortality that's associated with that. Really, the more severe the acute kidney injury is, the worse the outcomes and the worse the CKD progression, right? And so that's a new thing that we're really trying to make known in nephrology literature, is that acute kidney injury survivors are still, even if they recover, they're still at risk for developing long-term sequelae and need to be monitored for this. So moving along, so what can cause acute kidney injury? Well, there's a lot of things. So it's very often that in my consult notes, we say multifactorial. So it doesn't even have to be one of these things. Usually, often in our hospitalized patients, there's several insults that are involved. So looking at prerenal insults, so this is really anything that decreases overall perfusion to the kidneys. So that can be hypotension, which can be due from sepsis or low blood pressures, hypovolemia, so our patients with hemorrhages or dehydration or burn victims. And then really what we probably see that most frequently is down in the ICU are patients that are having, decreased cardiac output or decreased effective circulating volume. So those are our patients with sepsis, our liver failure patients, and then all of our cardiac patients that are in heart failure. And then one other thing to keep in mind is anything that changes our auto-regulation at the level of our glomerulus, right? So if we're giving medications like NSAIDs, ACE inhibitors, calcineurin inhibitors, those are all changing the effective circulation through our glomeruli and is going to affect our renal function. Intrinsic causes. So when you look at like the glomerular level, those are all the things that we deal with, right? So all of our glomerulonephritis, our vasculitis, hypertensive, glomerulopathy, and then all of our TMAs like HUS and everything, our thrombotic microangiopathies. But then there's a lot of different causes of interstitial injury. A lot of intrinsic causes can be due to other things that aren't necessarily kidney-based primary causes. So ischemia, sepsis, interstitial nephritis, which is, a lot of times drug-related. And then you get into all these drugs that are really, when most of our nephrotoxic drugs really have an effect at the level of the tubules. And so we're looking at, our contrast, our anti-infectives, a lot of our hem-onc medications. And then we also have this classification of post-renal injury as well too, right? So this is all of our obstructive things. So if all of our kids with congenital abnormalities of the kidney and urinary tract, they have all these possible areas of obstruction from the ureters down to the bladder and the urethra. And then there can be new, developed causes of obstruction. So blood clots, kidney stones, tumors, things like that we have to watch for as well too. So I don't know if this cartoon's appropriate for a pediatric lecture, but I thought it was pretty cute with the little shriveled up kidney. So, this is a study out of Texas Children's where they took a 3-year period and just looked at what the most common diagnoses in a pediatric center were for acute kidney injury. And so they saw 21% had ATN or dehydration, so pretty common, right? And then nephrotoxic drugs were also quite common. I mean, that's, almost 20% for both of those. Sepsis is common. There was a group of unknown that was really large, but the key that I wanted to make from this study was when they looked, only 7% of the patients had a primary kidney disease. So again, we're looking at this not being a primary kidney problem, but kind of a hospital-wide problem. So this is a chart out of these KDIGO guidelines that we use in nephrology. And so what are the causes that we see of acute kidney injury, and what are kind of susceptibilities in our patients that we need to be aware of? What are these risks? So exposures within the hospital that are frequently associated with acute kidney injury in studies are, of course, all these critically ill patients that we talked about, patients with sepsis and circulatory shock, trauma and burn victims, that makes sense. Cardiac surgery, I think we all know that we follow a lot of those patients from nephrology down in the ICU, with the nephrology consults in the ICU, and nephrotoxic drugs, radio contrast, and then I don't know if we see it that often, but they're listing poisonous plants and animals. So susceptibilities, I think a lot of times make sense on all these, dehydration. Advanced age, we don't have to worry about as much in pediatrics. I think if the patient has underlying chronic kidney disease, that's something that, we're all aware of, that they're probably going to be at increased risk of having injury when they're sick and in the hospital. All of our kids with chronic diseases, I think we're becoming more aware of, right? So we know our cardiac kids, our CFers, all of our transplant kids, we know that they have, chronic illness and are going to be more susceptible to kidney injury. Some of the things I found that were interesting that made this, though, were, and again, these are more in adult studies, but female gender, Black race, I thought, and anemia, I thought those were interesting susceptibilities that maybe we're not all thinking about. So anemia, I think, would be a huge thing that we probably underestimate, that could be making a patient more susceptible to kidney injury. So I tried to take this diagram to kind of just, again, move through what we kind of envision as kind of the progression of chronic kidney, or of acute kidney injury in the hospital. So I think we have our patients that come in and have normal kidney function, and then they have this period of time where we're treating them and they're seeing all these things like medications and, maybe hemodynamic instability, things like that are putting them at increased risk. And then at some point, this time of damage occurs. And then eventually after this damage, then we see this decrease in GFR. This is when we're seeing the increase in creatinine, we're seeing the change in urine output. And then this is the period of time where if we act, hopefully we can limit injury, but if we don't act, then we kind of get into that more severe AKI stage, and we're looking at kidney failure. And then again, if we don't treat it and kidney failure progresses and we don't do something like dialysis, it'll eventually result in death. And then at any point along the way, these patients are due to have, complications. And any of those complications can result in death. This pointer. Okay. So essentially point I wanted to make is really what I feel like a lot of what we do for acute kidney injury right now is working when we already have this decrease in GFR. So what do we really do for treatment of AKI right now? So really, unfortunately, our treatment is at this time really just largely supportive, right? So we kind of go through and identify the etiology, what we think could be contributing, why we think this bump in creatinine happened. We do a thorough history, we do physical examination and try to find the cause. And then we really try to reverse the insult to the kidney, right? So we get rid of any nephrotoxins, or try to at least, decrease those nephrotoxins that we're exposing the patients to. We try to do, volume resuscitation, or vice versa. If we're seeing that the patient's already fluid overloaded, then we already are into the fluid restriction area, right? And then we try to, hemodynamically support these patients as much as possible. So if their kidneys are struggling, we'll always, as the nephrology team, be like, they need more blood pressure, right? So, and then we try to support them with dialysis if we need. And then there's always these questions of what else can we do to manage acute kidney injury when it's already happened? So is there a role for diuretics in this? Is it right to fluid restrict? Is it right to nutrition restrict is always the question that comes up in the ICU. We have to maintain those electrolytes, right? So we're monitoring electrolytes and acid base closely to watch for those kind of, those effects. And then hopefully you're consulting your friendly nephrologist, right? So essentially, what our KDIGO guidelines say is that once you're kind of heading into this risk, you should be stratifying how severe you think their acute kidney injury is. You should be, again, looking for all these exposures. So far, this is what I feel like we do well at this. So we do all these recommendations here at our center and as a nephrologist. And then we have to test these patients and follow their serum creatinines and urine outputs closely. And we have to kind of individualize how soon we're going to follow, how quickly and how often we're going to follow up on the creatinine and the urine output and everything based on how sick the patients are, right? So then getting into evaluation and management, what do our kidney guidelines currently say? So they say to evaluate the patients promptly, again, monitor their serum creatinine and urine output or that have a high creatinine, manage patients with acute kidney injury according to their stage. So they have some recommendations that we'll get to, like if they're a more severe stage, they're kind of adding on additional things that we should be thinking about. So if the patients have had 3 months after 3 months after an episode of acute kidney injury, we should probably be looking at their kidney function to see if it's resolved or if it's worsened, and if we're now going to give them the definition of acute kidney disease or chronic kidney disease, right? If patients have chronic kidney disease, then we're supposed to be managing all these things that come with it. So that's kind of our job as the nephrologist to kind of watch for those electrolyte abnormalities, hypertension, proteinuria, that kind of stuff. And if patients don't have chronic kidney disease, then we have to think about if they're at increased risk for chronic kidney disease. And if we need to still kind of follow them long-term is really the kind of decision we have to make when they come back to see us after having acute kidney injury in the hospital. So I thought this was a nice flow chart. It's a little complicated, so I'll just try to go through it quickly. Are you even able to read it? It did not come up very well. So essentially, once you have acute kidney injury, they want you to kind of see if they want you to take a physical exam. They want you to look at their trends of lab values and give them an acute kidney injury stage. And then if you feel like the acute kidney injury cause is from decreased perfusion, then they want you to do one of these kind of methods to resuscitate, either address the heart insufficiency, address with, fluids if it's dehydration. If there's not decreased perfusion, then they want you to look into further causes. So this is kind of when you probably want to get your ultrasound and make sure there's no kind of obstruction or anything. And then if you're still not finding a specific diagnosis, if you don't find obstruction, then they want you to look for other more specific diagnoses. So looking in some of those more primary kidney things that we follow for, like glomerulonephritis. And then eventually, oh gosh, I cannot read that. And then if it's just non-specific acute kidney injury, then they want you to go more into, looking at infections and toxins and things like that. So this is kind of just to kind of help you on that history, like what things to ask so you're moving your way down and kind of ruling things out. And that's a lot of what we do on our nephrology consults is kind of just work our way through this flowchart. So what's next then? So I think we already went through that. So then what do we do to treat then? So in the absence of, these are their recommendations then for treatment. So we can see if we're kind of, doing this as an organization. So I think we do. In the absence of hemorrhagic shock, they're really saying that you should use isotonic crystalloids rather than colloids for initial management of volume expansion, right? We just have to get more fluid in there, start perfusing the kidneys. They are recommending using vasopressors in conjunction with fluids if you're having shock. We suggest using protocol-based management of hemodynamic and oxygenation parameters. So that kind of goes to, our ICU colleagues, like if they have a kind of standard of care for doing resuscitation of these critically ill patients, right? And then interestingly, the guidelines also get into what to do kind of when these patients are kind of fully resuscitated and then, within the ICU is what I kind of think of here. So really, they're still making a big point about how we need to focus on nutrition. Now, these calorie parameters and everything are for adults because these guidelines, of course, are adult heavy. But I think that's something that we have to think about is through all this, we still need to be making sure that our patients are getting good nutrition. And they're really, I thought the D6 statement right here, I think is interesting and something kind of as a hospital that we need to think about is they're really suggesting rather than getting into the point where we protein restrict, that's really the point where if we were pushing nutrition, we don't want to protein restrict, we don't want to fluid restrict, then we're probably looking at needing to be more aggressive about doing renal replacement therapy until this acute kidney injury has improved. We need to think about maybe dialysis earlier so that we're not restricting nutrition in these patients. And then, again, they're just talking about how important it is to have protein administration in these patients, and they're giving recommendations on how much protein for, again, adult patients. And then, of course, it's always preferred to feed your patients enterally instead of IV. So then getting into the question, are diuretics effective at the prevention of acute kidney injury? So this is a tough question, and there's a lot of different studies, randomized control trials, but the numbers are small. There's a lot of systematic reviews. I chose to kind of summarize the literature search that was in our KDIGO guidelines as far as what their review of the literature is and what their recommendations are. So really, in general, they are not recommending prophylactic Lasix after cardiac surgeries to prevent acute kidney injury. Studies haven't shown that that really works to use them prophylactically. You're supposed to really watch using diuretics in patients with contrast-induced AKI. The studies of diuretic use in those patients with contrast-induced acute kidney injury, they actually saw worse outcomes. So again, and that makes sense really, usually, and the mainstay of therapy, and we'll talk a little bit more about that, is you want to get more intravascular volume. So if you're using diuretics in these patients, you're putting them more at risk of getting those effects of the contrast. They really saw that with diuretic use in all these reviews that there was no significant reduction in hospital mortality, no significant reduction in renal replacement therapy numbers. There is some thought of maybe, studies vary. Most studies definitely say that there's no reduction in the time on renal replacement therapy. Some are suggesting that there is a reduction in renal replacement therapy numbers. They are saying, though, that diuretics can be helpful when you really get into the fluid overload, of course. Like if you can keep a little bit of urine output going, that can help, reduce your fluid overload and help, improve your mechanical ventilation. So there's a lot of debate on whether, so that's the one thing, is that if your patient is anuric and fluid overloaded, diuretics might help. But there's not a lot of good studies to show whether or not that diuretic in a patient with acute kidney injury worsens the AKI. That's still a question. But really the KDIGO, the nephrology guidelines are really recommending that there's that they don't really strongly recommend diuretics in the management of acute kidney injury. So, sorry, I jumped ahead then. So these are the recommendations that exist in our KDIGO recommendations. So they really don't recommend using diuretics to prevent acute kidney injury, and they suggest not using diuretics to treat acute kidney injury except in those patients with severe or significant fluid overload for helping that volume management. So then I didn't have time to cover studies on all these, but just to kind of let you know some other things that have been in the literature on their effects of preventing acute kidney injury and where do our current guidelines as of now stand for that. So really the low dose dopamine that has always kind of been debated on whether or not it's protective for renal perfusion, they're really finding that those studies aren't really playing out. So really right now they're not recommending the low dose dopamine. The studies with phenoldiprem haven't really played out, so that's not really a suggestion from our guidelines right now. There's some studies about atrial natriuretic peptide, and they're not suggesting that in our guidelines based on the outcomes of those studies, and there's decent grading for the significance of those suggestions, those recommendations. They're not suggesting using growth factor for preventing acute kidney injury. But interestingly, for our neonatal colleagues, they are recommending that a single dose of theophylline may prevent acute kidney injury and is useful in patients at high risk of acute kidney injury after perinatal asphyxiation. So this is the chart that kind of just takes through the KDIGO guidelines went through and again showed the patients at risk for acute kidney injury and then the more severe staging, right, the 1, 2, and 3, and what kind of management they're suggesting at all these points. So the patients at risk, we should be thinking about their nephrotoxins, and really at risk throughout the whole thing, we should be looking at their nephrotoxic medication exposure. We should be looking at their volume status. We should be looking at their hemodynamics. We should be monitoring their creatinine and urine output more closely. This is more for adults, but avoiding hyperglycemia with if patients are hypoglycemic, they're seeing that changing their outcomes with acute kidney injury in some studies, not been proven in pediatrics, not really well studied. And then looking at what you're using for contrast and trying to avoid that. And then as you go more into your stages, so once you're looking at stage 1, they're wanting you to start that workup of looking at what the other causes could be. Stage 2, they're wanting you to try to change drugs if they are on anything, making some changes in therapy, can start considering dialysis and considering if this patient needs to be transferred to the ICU if they're not already in the ICU. And then it turns out it's not just us here at Children's that are annoying about the central catheters. So it's actually a big push for patients that, again, because of the risk for chronic kidney disease progression, once you hit a AKI stage 3, they're really wanting us to start looking at what we're doing for access in these patients. And we don't want to be putting in catheters like subclavians that could be limiting possible future access for these patients if they end up on dialysis in the future. We don't want to be abusing and losing all our vessels. So if we can stick with something like an IJ that is not going to cause stenosis in more vessels, that's the best for our patients. Because again, and this is even adult recommendations that they're doing this, but if you think about our pediatric patients, if they're having kidney injury now and kidney issues and they end up on dialysis, they're going to need several transplants during their lifetime, maybe 2 or 3, and that means several courses of dialysis. So anything we can do to save their vessels now is a big thing. So back to our card of what we pretty much do for, AKI right now. Again, it's supportive. So sometimes I feel like a lot of times when I, go anywhere in the hospital for an AKI, consult, I feel like everybody's kind of just frustrated once we're involved because it's really, well, what are we even doing once they have AKI? Or are we just really watching? And it's just kind of non-rewarding sometimes, right? It's like we don't have any miracle thing to make the kidneys better. I wish I did, because it seems like the parents are so disheartened when I tell them that there's nothing we can do to make the kidneys better. So then going back to the same figure that we looked at with the progression of acute kidney injury, kind of the new direction moving forward is instead of intervening here like we're currently doing, we need to be looking at intervening here before the injury. So really, management of AKI should really be more preventative rather than occurring after the fact that the GFR decrease has already occurred. So moving into that, well, what can we do to prevent things big thing within pediatric literature right now is really working on reducing nephrotoxic medication exposure in our hospitalized kids. So, so this is again just kind of a schema of the, what happens. So we have our nephrotoxins exposed, we get kidney injury, and then, right now we're kind of doing acute kidney injury monitoring, and then kind of following the severity of it, right? And then following up and monitoring closely. But again, the new push is, can we be acting here? Can we avoid nephrotoxins? Can we reduce the nephrotoxins that we use and actually prevent injury before it occurs? So this was a study out of Texas Children's, where they did a retrospective chart review of non-critically ill children, so that's important to note. They found that even in their kids outside of the ICU, they met criteria for acute kidney injury 33% of the time, which is a really high number. I think all of you guys would agree. I mean, a third of the kids not in the ICU with acute kidney injury on this chart review, I think that's pretty scary. And so what they found was essentially that patients who had acute kidney injury had exposure to more nephrotoxic medications and for over a longer duration of time. Even with being exposed to one nephrotoxic medication, they found the odds of acute kidney injury increased, of having acute kidney injury increased. And as you were exposed to more nephrotoxic medications, you had an increased risk of acute kidney injury. So when you come down to one of the figures from the paper when they were looking at the positive predictive value. So this is medication exposure. So this is being exposed to increasing number of meds during the duration of the hospitalization. So maybe they had exposure to an NSAID, and then later on in the hospitalization got exposure to an aminoglycoside. So this is just during the total hospitalization, they got exposed to this many medications, and they didn't have to be at the same time. And you can see that the positive predicted value of developing AKI increased as the number of medications increased. And then the second group here was when they actually looked at how many concomitant nephrotoxic medications were being used. And again, a similar increase in the positive predictive value of developing acute kidney injury. And then in both groups, the interesting thing that they found was really, they kind of made note of this on both places. The increase from 2 to 3 nephrotoxins was really kind of what they kind of considered kind of that kill point of, once you add in that third medication, that's when the amount of AKI doubled essentially. And so that's kind of an important thing that moving forward in some of these studies that we'll look at, they always kind of really targeted 3 medications as being, and that's why. So after that kind of initial study, Stu Goldstein, who's now at Cincinnati, he was at Texas Children's, he's really kind of taken this big initiative and has started these NINJA studies at multiple centers within the U.S. But his preliminary work, he kind of always rolls everything out at Cincinnati first. And so the first project that he did at Cincinnati was to just use Epic to track the nephrotoxic medication exposure. And so again, he's not focusing on those critically ill patients. He's focusing on our average patients in the hospital. And he did this project for about 4 years at Cincinnati Children's. And essentially what he defined as a nephrotoxic medication exposure was having an IV aminoglycoside for greater than 3 days or greater than 3 nephrotoxins at a period of time. So I think that's actually, I think all of you would agree, I think that's actually a substantial exposure. So we're not just even talking about, we're not talking about minor exposures. But and so then essentially what they did for the project was, once a patient met these criteria, an automatic flag went to their pharmacist, and their pharmacist then was aware of it. They had a clinical pharmacist on rounds, and essentially at that point, the clinical pharmacist just recommended that the patient start having daily creatinine monitoring. And if they could, they would recommend, a change in therapy, either a change to a different drug or a decrease in the drug or monitoring levels, right? But they made very clear in the study that they never required that the primary team make a change in the therapy. So what medications did they consider nephrotoxic in the study? Well, this is an updated chart. I wanted to, they used a slightly different chart, but this is with the current NINJA studies, this is the current chart that they're using in any of them. This is a new chart from 2019. So kind of interesting to look over. Sometimes there's a lot of medications that weren't even necessarily really on my radar. Pamidronate was one that I think we're starting to pay more attention to. Pentamidine was interesting. Of course, like all the contrast is on there, but Jadnu's on there. I had to point that one out to Dr. Ford. Is Dr. Ford here? He was asking me about putting a patient on Jadnu the other day and if there were any kidney risks with that. So a lot of different medications that we need to look at. So what were the most commonly used nephrotoxins? So really the biggest problem, or the biggest numbers were in the anti-infectives, which I think a lot of us would guess. But so aminoglycoside use was very high. But then I thought it was interesting that all of our calcineurin inhibitors and mTOR inhibitors was actually the second group. So if you think about it, like we have a lot of patients that are on numerous of these medications, right? Like think about our, kidney and heart transplant patients. So they're all on ACE inhibitors and calcineurin inhibitors at the same time. And then who's using the nephrotoxin? So none of my hem-onc friends are here today, but I always give Dr. Ford and Dr. Coulter a hard time about whacking nephrons. And it turns out that they are trying, look, so they were bone marrow and hem-onc were the highest, I think we'd all predict that, but they were the most frequent users of nephrotoxic medications. But pulmonary, and I'm guessing that's probably because of the CF population, right? But I thought it was interesting. Look at ortho with all their NSAID use was, the number 3 offenders. Cardiology, you guys made it up there too. Don't worry. So what they see after this 4 years of implementing this nephrotoxin pharmacy prevention program, or awareness program, I guess. It's not even really prevention. So they found 3,243 episodes of nephrotoxic medication exposures. So again, and that has to meet one of those criteria of the aminoglycosides or 3 meds. And they found that those occurred in 1,700 patients. So several of those patients were getting exposed to meeting this criteria repeated times during different, single or different hospitalizations. And so 170 patients had greater than 2 of these exposures. There was 575 acute kidney events during this 43-month period. And then what they saw from implementing this simple program, they saw that their nephrotoxin exposure rate decreased by 38%, which I think is huge, and their acute kidney injury rate decreased by 64%. So here's some of the charts from some of the figures from the paper just showing that reduction. So this is the nephrotoxic medication exposure rate, and they just kind of did it per 1,000 patient days. And you can see that in the study, they were really proud to show that they had 2 major points of kind of in the curve of seeing this decrease in nephrotoxic use. They weren't exactly sure, why there were 2 big downward trends within the study. And they tried to go through in the study and kind of show other working groups that were occurring in the hospital at the same time. They were at different points, they were rolling out different quality improvement projects that maybe affected it. But overall, if you look at their rate of nephrotoxic exposure from there to there, I think that's pretty impressive. And then looking at their acute kidney injury rates, so again, had 2 major decreases within the acute kidney injury rates. And they did some calculations and essentially, I didn't make it onto my slide. They had, big numbers like over 300 they prevented 300 nephrotoxic medication exposures, and I can't remember the exact number for how many, acute kidney injury events they think they reduced with these reductions, and I think that's really impressive. And through the studies also, they had other things that they commented on, but looking at like their infection rates and things like that, they didn't think that with reducing some of like the aminoglycoside use and things like that, they didn't overall see any change in like blood cultures or anything like that. Like they weren't providing worse standard of care for their patients with being cognizant about how many nephrotoxins they're using. One other thing that kind of came out of the study that they saw, and then there's actually a lot more studies now, is paying more attention to the nephrotoxicity of Zosyn, of piperacillin tazobactam. And so I wanted to make sure to kind of point that out because I think Zosyn is one of those that gets used frequently that maybe we're not giving it credit for its nephrotoxicity potential. And so this was just a systematic review that was done in adult literature where they took 15 published studies and some abstracts. You had 24,000 patients and saw, again, they saw 16% acute kidney injury. So this is, how this acute kidney injury rate always varies depending on what the study is. But the acute kidney injury rate was 20% when you combined vanc and piperacillin, and only 9% if you use those antibiotics separately. So there is definitely a combined effect that if you're using them together, we're seeing more acute kidney injury. It's potentiating the toxicity of these medications. And so, back to our KDIGO recommendations. So what are they suggesting? Well, so they're suggesting that you should not use aminoglycosides if there are alternatives available. If you have a patient with normal kidney function and an glycoside is administered, try to do it as a single daily dose rather than dosing it several times during the day. Then they say essentially if you're dosing it single daily dosing, you need to be checking a level within 48 hours. If you're doing multiple dosing in the day, you need to be checking every 24 hours. And then they make some recommendations on how to use some of the other nephrotoxic medications like the amphotericin and some of your azoles. Briefly wanted to talk about contrast-associated acute kidney injury, but this was a whole nother monstrosity in itself. There's so much data out there. They actually just had a really big forum at the ASN meeting that I went to last week, and it was a packed ballroom. It was probably one of the biggest lectures that I went to the whole time. So it's definitely an interest of everybody on whether or not we're believing still that this is a real thing, and because there is still debate on whether or not it's even real and then who's at risk. So everybody's definitely interested. And essentially, they said at one point in the meeting that in 1 year, there were actually more systematic reviews done on the topic than there actually were controlled studies. So they kind of said that was like a new all-time low for nephrology studies, that we're just keep studying studies that are out there instead of improving our study design and getting the numbers that we need to prove this question. So there is some debate still on whether or not this is real or if we're overestimating the risk. And really in adult literature, they're really talking about how this fear of using contrast in our patients and our fear of doing no harm is actually preventing some patients from really getting necessary therapies, especially like they were talking a lot about, like coronary angiograms and things like that. And so really, I think the key, though, that came from everybody kind of discussing at the meeting is that we need to identify patients that are at higher risk of contrast-associated AKI. And so really, it's patients that are having acute kidney injury or CKD or have chronic kidney disease at baseline are really at risk. And then they kind of gave some guidelines. So if you're thinking about doing angiography, you should be worried if a patient's GFR is less than 60, and then CT scan. There was some debate on, but it's kind of a GFR of like less than 30 or 60 is when you should be kind of thinking. I know that's a wide gap, but you should always be thinking if there's an acceptable alternative study that can give you the same answer without the risk, then that's a win-win situation. And then for patients that are at increased risk, really they're just saying to implement the best evidence-based guidelines that we have for preventing contrast-induced nephropathy. And I have another slide on that, but that's still kind of to be debated, right? A lot of those studies, we're not sure if they're all playing out to be what we thought they were. But across the board, everybody's talking about using the lower osmolar contrast agents. Do we have anybody from radiology here? When I've asked before, they tell me that here in general, they always are trying to use these and using the lowest dose possible. So I think our radiologists are doing a really good job from their end of trying to eliminate this injury. And then this is a chart that I put together based on some other slides, trying to show where we're at with knowing, it's not projecting very well, but where we're at with knowing which therapies have benefit for preventing contrast-induced injury, contrast-induced AKI. So what have been proven ineffective, according to the literature, and all the systematic reviews that have been done, is calcium channel blockers, ANP, loop diuretics, which we already kind of discussed, dopamine, mannitol, phenoldiprem, and actually hemodialysis. And I think that one gets overlooked a lot of times. Unclear benefit is theophylline, aminophylline, ascorbic acids, statins, hemofiltration, Renal Guard, which is actually like a product that's coming out that's just a specialized IV solution that they're trying to promote as being protective against contrast. So it's a product in itself that I don't even know. I'm sure it's under patent, but I don't know what's involved in it. But this company is actually trying to sell it as an IV fluid that you should start on your patients that are having contrast administered, IV contrast. And allopurinol and acetazolamide really haven't been studied enough to know if there's a clear benefit. Things that have been effective, what we're thinking is most effective at this point is really just isotonic IV fluid, so hydrating these patients at increased risk and then using the low osmolar contrast solutions. So then back to my same diagram. So again, we just talked about where we think we should be acting now to try to prevent acute kidney injury and how are we going to do that. So another hot topic in acute kidney injury right now is trying to find biomarkers that can help us identify acute kidney injury earlier. So, oops, and I'm looking at time. So I'll go through these fast. So essentially, if we can identify before the creatinine bumps, we'll be in a better spot. Right now, we're sometimes using cystatin C in more of our patients, but the problem is it really only elevates around the same time as creatinine, so it's not a better biomarker. The new thing under investigation is all these kind of urinary biomarkers that you can measure within the urine. And actually, NGAL, the top one, has been better studied and is actually commercially available now. And we've actually had a rep come and ask us if we're interested in implementing it here at Children's. And so that's something that I was wanting to bring into the discussion. But it's essentially a urinary biomarker from the distal tubules that is excreted into the urine. And studies have started to show that with severity of acute kidney injury, so again, this rifle criteria, they're seeing elevated levels of the urinary NGAL levels. And so there's thought that this could be a good marker of acute kidney injury earlier on. And then here's when the patient met, these are when the patients met criteria for acute kidney injury, and the urinary NGAL levels are elevated before the day zero. So that's where the thought is that we could identify acute kidney injury earlier. Sorry, I'm going to get through these so we can answer some questions, but people are proposing then this renal angina index. So if we can essentially give patients a score, and if they meet a certain score, then they're at increase for acute kidney injury, and maybe we should be, implementing closer monitoring and everything. And so these, so far, the angina index don't really have a high positive predictive value, but they're really good at saying the patients that won't develop acute kidney injury, right? And their negative predictive value is pretty good. And this is just like flow diagrams that kind of go through that risk. And with that, you have to be calculating the percentage of fluid overload in your patients. And then we all do it, but I didn't, a lot of us don't know that there's a specific name for it, but a furosemide stress test where you're essentially giving a dose of Lasix to your patients and then seeing how well they respond with urine output. And that can be a prediction of if they're going to be able to come off dialysis, if they're going to go on to develop worse kidney injury. These haven't been validated in pediatrics because it's really hard to give clear criteria for urine volume when our patients vary so much in size, but adults are really working on this kind of furosemide stress test and risk profiles based on how good they pee in response to Lasix. So that's kind of my last slide then, is really like, should we be considering implementing more of these practices at Children's to kind of, since this is such a common problem. So should we be having a clinical pharmacist at all rounds? I know a lot of people have clinical pharmacists, but not all. Should we be doing in-house cystatin C and NGAL? And I think that's something that we need to look into more. Should we be having an acute kidney injury angina score? And should we maybe propose that we have a system in Epic that flags if our patients either have a doubling of their creatinine or greater than 10% fluid overload? Could we use Epic to flag this and maybe have like an automatic nephrology consult or something? So in conclusion, AKI is real. Pediatric AKI is due to other illnesses. AKI causes increased morbidity and mortality in our patients. Recognition and prevention of AKI may improve our outcomes better since we don't have a good treatment. And prevention of nephrotoxic medications, I think, is a key way to prevent AKI. And then urinary biomarkers are kind of a new exciting thing that might help us care for our patients with acute kidney injury. And there's my references. And any questions? Yeah.
You showed a list of drugs that might be protective during the use of contrast. Do you have anything similar for use of aminoglycosides?
Oh, preventing? I don't, but that would be a nice chart to have, but I'm not aware of any, but I didn't look specifically at that question as far as reduce the risk, but that would be very important in your patient population, yeah. Have you seen anything like that?
No, I was hoping you would.
Maybe in my next grand rounds. Anybody from the ICUs or cardiology that you guys have any opinion on this topic, or?
Is there work or research questions still to be done with phenoldiprem, and whether it's bypass or any of the ICU settings?
I don't know that, but I think people are leaning away from it more, but I think there's always, ways that we can always alter, like when we're using it and things to, prevent that. I don't know the answers to that if they've looked at, prevention studies or anything, if we're using it earlier. Like if we're using it when, I think that opens up a whole nother window if we can start to treat patients if they're just flagging with biomarkers. That's kind of a whole nother question, because right now, again, we're using some of these agents like phenoldiprem and everything after the creatinine's already spiked, but so maybe they're not effective then, but if we start to use them earlier during this risk period. I don't know.
Some centers have used aminophylline. I thought your comment about theophylline in the NICU was interesting. Aminophylline is supposed to work similarly as far as increasing renal blood flow, and the thought behind phenoldiprem is it doesn't help your, it also drops your systemic blood pressure, so it's tricky.
Do we have anybody from pharmacy here today? Yeah, so I don't know if you guys have any thoughts on, feeling strongly one way or another for implementing some kind of program like they did similar at Cincinnati, because I think that's a really exciting thing that wouldn't be too much work if we can utilize the medical record system to work for us, and then just have simple, it wasn't even really a big change in patient management, but just kind of an overall hospital awareness that they saw, even, they saw the NSAID use go down in orthopedics because everybody had heightened awareness.
I think that would be super useful. There's always a question, of workload and staffing and all that kind of thing. That's what's possible versus, what would be beneficial. But that's something that I definitely will pass on to the rest of the pharmacy team. You've got residents and students here today, but none of the top pharmacists.
Yeah. Okay.
But yeah, we'll pass that on. It's super interesting.
Yeah. So, I think these are all areas that we can work on for quality improvement within our hospital. So if anybody has interest, I think reach out to any of us nephrologists. I think we'd be interested in looking at things. So lots of possible resident QI research projects, guys. Wink, wink. So, okay. Well, thank you.